Welcome to our panel, Helping Healthcare Heal Itself. My name is Tara Dragert. I'm the Chief Product Officer for Surescripts, and I'm delighted to intro this panel for you today. So at Surescripts, we have been working on this for 22 years. And yesterday, we just released our National Progress Report. So the first thing you see here is so many more professionals are joining the network. And of course, the utilization just continues to grow and grow. And each one of those transactions is a person. Each one is a person with a family that wants to just get back to their lives. And most of the growth that we're seeing, one thing that stands out here is the growth in pharmacies or pharmacists that are prescribing on the network. And we expect to see much more of that, especially as payment and reimbursements continues to change and reinform and support a broader, diverse set of providers providing care. So we're very, very excited about that. Well, most of us here aren't providing health care. I would say most of us here aren't even in the technology business. The business that we are in is returning power back to patients and the people who care for them. That's what we're trying to solve. And that's what this panel of experts is going to be sharing with you, how we can help healthcare heal itself.
So no talk at HIMSS in 2024 about interoperability. Can't include all the great work that's happening led by the ONC and the Sequoia project with TEFCA. We have made a lot of progress over this past year. We have some QHINs live. Surescripts is a candidate QHIN, or the Surescripts Health Information Network is a candidate QHIN. You know, Dee Dee, I'd love to hear from you. You have been kind of right in the driver's seat of all of that work. What are you seeing today, and what are we going to see over the next 12 months?
Why haven't we solved the interoperability problem? Well, it's because there's an ongoing change with the ONC regulations around US CDI. We're going to continue adding more data as we move. And a lot of times that has to be implemented at that last mile. Just because a vendor knows how to do it doesn't mean they've implemented it in that hospital system. So we've put together a taking root movement to try to get some of the guidance we published in December to take root. So we're going to work on it, and we're grateful for all of the partners who signed up. We have over 60 organizations that are working with us to help us with that avenue.
We know that care doesn't just happen in those 15 minutes in your doctor's office, and we know that it's not contained there. So if a patient shows up at a pharmacy, that information can be there. That if anybody on the care team is supporting them with a prior authorization, that clinical information can support them to really accelerate that time to therapy. And so some of the big challenges that we have that are worth solving for are making sure that we've got the right patient. So really that master patient index, that right patient, the right information. So taking that data, and though it is the interoperability and the exchange is happening across the nation, moving it into non-treatment use cases and making it actionable.
As we sort of think about, being able to share that information across the different members of the care team, it's empowering all of those members. And frankly, in my view anyway, one of the most overlooked members of the care team, the patient. Making sure that information is available to the patient in a way that they can understand and follow, that it's clear, and making sure that it's available, that they can share it to whom they need to share it to. I was having a conversation earlier today, and someone used the following example. A patient, say, lives here in Florida, is skiing in Colorado, has an accident, they're unconscious, they need surgery. This patient, unbeknownst to anybody, has malignant hypertension. They get anesthesia. Next thing that happens, that patient dies. And that's not a great way to start. Interoperability can help us prevent those things.
We talk a lot about pharmacy interoperability, and people are like, what does that mean? And to me, it's like pharmacists could be part of the care team. They need access to patient records, right? And to support the patient care. They don't need the entire thing, but they need, bits and pieces of it. And so having that vision of really bringing everyone, the patient, the pharmacist, everyone into the care team is so important. So
one of the biggest problems, I think, is that, the more we share information, the more information there is, and there's enough information overload to start with. I was at a conference recently where someone suggested that an inpatient chart was the average length of half of Hamlet. No one's going to read half of Hamlet before they see every single patient. So how do we surface the right information to the fore so that people can see what they, quote, need to see? And that's where it gets tricky, because what I need to see is different for me as a primary care doc than it is for a surgeon, than it is for a cardiologist. And how do we, create those summaries in an appropriate fashion that really support those different users?
What are some words of wisdom you have on how to prepare for some of these upcoming changes, whether it's new interoperability, dealing with the data tsunami, helping think about that balance between patient privacy? What's your words of wisdom for this audience here? So Pooja, we'll start with you.
I think we're in this next wave where we're now actually seeing pharmacy interoperability. I would say for those in the audience, pay attention to pharmacy, include pharmacists. They're an important part of the care team. We're going to start seeing that more and more. And so anything providers, health tech vendors can do to think about the pharmacist side of things and how we can include them in the care teams, I think that's what we need to focus on.
One that's often said, but often hard, be open to change. Everybody sort of says, as we look at these new ways of doing things and this new opportunity to incorporate information, you have to think about how your workflow changes to make use of it. And that's often easier said than done.
And playing on that line, I'd advise you to think about usability in all projects. So a lot of the meaningful use certification funds put in an electronic health record. And that was great because, in 2010, we had less than 20% of the hospitals connected. Now 95% are connected. But we need to make sure that the data is coded properly so we can have semantic interoperability. Back to your point, we don't want duplicate data. We want the systems to de-identify or deduplicate. I got the same allergy 10 times. I don't want to see 10 in a list. So thinking about usability in all projects, and ask the questions if you're a user or you're working with somebody that is a user.
I would have to say I'm really excited that we get to take all of the interoperability work that we've been doing for the last 20 years. We've got some awesome building blocks to expand it beyond treatment use cases into non-treatment use cases to really empower the patient and all of the people caring for them across the entire care continuum.
The work that we're all doing is so important. And, I just look forward to the day when we don't have the fax and the hospitalists like me have that information they need in that concise, smart way so they can make the decisions they need at that moment. Thank you.